Hello, my name's Philip Morgan. I'm Professor of Optometry at the University of Manchester, and what I'd like to talk about in this presentation is how we might be able to approximate axial length based on conventional optometric measures with equipment that we have readily available to us in a standard consulting room. And I think the context of this is twofold. Firstly, many of us increasingly know about the surge in myopia that we're seeing worldwide. So this is becoming a major issue. Another key part of this is that we have approved products now coming available onto the market for myopia management or myopia control. In this chart, what we can see in the open symbols is an increase in the prescribing of soft contact lenses for myopia management when those lenses are prescribed for children. We can see for the early part of the previous decade that really this was very unusual. But perhaps now, over the past 4 or 5 years, we've seen this increase to the point where perhaps about 5% of contact lenses which are soft, when prescribed to children, are for myopia management. So this is increasingly part of our practice. And this general area, I think, is something that's going to be a major focus for all of us in the contact lens world over the coming years. And it's important for this reason, that an eye which is myopic is an eye that is too big for its optics. So in people with very large eyes of 30 millimeters or longer, it's thought that a great majority of those people will exhibit myopic maculopathy, for example, and this is a sight-threatening condition. So understanding the length of the eye, I think, is getting increasingly important for us. So how can we measure the length of the eye to really shift the conversation away from considering myopia in terms of diopters, but towards millimeters? Well, there are a range of instruments which will do that, such as the ones shown on this slide. But these are relatively expensive, and at least at this stage in the increase of myopia management systems in optometric practice, I think beyond the reach of most optometry practices. So can we do this in a different way? Can we use more conventional systems like retinoscopy and keratometry, or perhaps moving to the next level up, systems that are increasingly available, things like measuring the curvature of the cornea with topographic systems and measuring refractive error using autorefraction. Can we use these two systems to allow us to approximate axial length? Well, why might this be even possible? Well, I was thinking about this some months ago, and it occurred to me that there are 3 intrinsic features of the eye which have to be inherently linked. We have the optics at the front of the eye, and we have the eye's axial length. And if there is a mismatch between these two, then we have some degree of refractive error. So if the cornea, for example, is too curved for its axial length, then we will have a myopic eye. Or if the eye is too long for its optics, then similarly we will have myopia. We measure refractive error on all of our patients on a day-to-day basis, and in many of them we will also measure the curvature of the front of the eye. And it seemed to me that because these two things are inherently linked, if you could measure the first two, then we might be able to get an estimation of the third of axial length. And if we convert all of these measurements to diopters, and we combine that with the spherical equivalent refractive error, then we might have a relationship that looks a bit something like this, where A, B, and C are parameters which we can calculate. K is radius of curvature of the cornea, and S is spherical error. Well, how could I test this theory? Well, I was very fortunate and in that I had a conversation with CooperVision, who had, at the time of the conversation, recently completed a large clinical study where all of this information was captured on multiple occasions on about 144 children. These children were taking part in a clinical study that was to explore the performance of the MySight product. And all of this information was held in this database, and I was fortunate to be able to get a limited amount of this database, the stuff I needed, which was the axial length data, the corneal curvature data, and the refractive error, or mean spherical refractive error data. And when I put all of this into a statistical model and found out what is the best relationship between these, well, this is what we get. And if we convert this around, we can actually see that we can measure or calculate or estimate A, that is axial length, if we know K, the radius of curvature of the cornea, and S, the refractive error. But I now had, based on the MySight data, I had measurements that were done for axial length during that study, and also what is calculated from this formula that I devised. And if we plot one against the other, we get a fairly good relationship, an R-squared value here of 0.83, which is fairly healthy. But more normally, if we wish to compare measures of two different sorts, we construct something that's called a Bland-Altman chart. And here is the Bland-Altman chart for this assessment. And I think it's important to understand what this is telling us. On the x-axis, these are the mean values between the two measurement approaches, so the average between the calculated measurement from the formula I presented and the actual instrument-derived measurement from the study. On the y-axis, what we see is the difference between those two approaches. So the difference between what was actually measured in the study and what was calculated based on this formula. Now, any data point along that red line on this chart means that there was no difference between the two measures. They were exactly the same. And you'll see there are a few points along that red line and some points above and some points below the line. And if they're above or below the red line, it means there is a discrepancy between the calculated value and the actual measured value. Importantly, the way that these plots are designed is to put a dotted line that represents the 95% limits of agreement. In this case, we could consider those to be the 95% confidence limits. And as you can see from the chart, most of the data points, in fact 95% of those data points, are held within these dotted lines, with 5% of the points outside of the dotted lines. What this tells us is that 95% of the time, the estimated value, that was the one derived from the formula, was within plus or minus 3/4 of a millimeter from the true value. That's around plus or minus 3% of the true value. And when I saw this chart, I thought this is a pretty good estimate of actually what's going on. So we can actually do something similar using both cycloplegic refraction results and non-cycloplegic results. In fact, we get something very similar for the two. That is, using the formula, we are within about 3% or within 3/4 of a millimeter of the true axial length value. Well, how can we sort of challenge this formula? This formula was based on one particular study done at one point in time using a particular protocol. So it was important to come at this, I think, from a different angle. What if we use data from another project? And I was fortunate enough to speak with my colleagues Sarah McCulloch and Catherine Saunders at the University of Ulster, who have done some outstanding work also in this area. They have looked at refractive change in children in Northern Ireland for many years in a project called the NICER study. And we were able to do something similar with their data set, which again ticked all the boxes. In all of these children, very carefully, they'd looked at refractive error, they'd looked at corneal curvature, and they'd looked at axial length. So we could use this formula to see what would this have predicted for axial length amongst their children cohort versus what actually did they measure. And that's summarized here. It's not quite as good relationship, which isn't a surprise perhaps because it's done very, very differently, but it's not too far out. It's about a plus or minus 3.7% accuracy on the predicted axial length versus the measured axial length. So again, I think this is a good result for using a formula like this. So if we want to bring this all together, what have we got here? Well, I think a number of things. Let's use the information we have at hand, which is both keratometry and refraction, to go about estimating axial length. If we're able to do this, it seems that we could perhaps move from this simple formula to developing some helpful in-practice tools, an axial length estimator maybe that could go on a website or onto a mobile phone app. It's also worth considering what this sort of formula approach is able to deliver, but also it's not able to deliver. The limits of agreement, the measure of sensitivity of this formula, as I reported, are about plus or minus 3/4 of a millimetre, or plus or minus 3%. So it's not really precise enough to monitor the very small changes we might see between each visit to the practice, or to measure the effect of a myopia management strategy. That would probably need a biometer, one of the more expensive devices I mentioned earlier on. But what I think it does do is a couple of really important things. The first is it allows us to categorize or bucket a young myope into low, medium or high axial length, for us to better understand exactly which of these three categories they would fall into. But perhaps more important still is it allows us to shift the conversation away from diopters but towards millimeters, because ultimately the problems that we see in later life of these pathological changes with myopia, it's not a diopter thing really, it's an axial length thing, it's a millimeter thing. And I think as such this sort of approach gives us a new helpful communication tool that we can use with our patients, and in the case of young myopes, with their parents as well.